So good evening, everyone. My name is Vikas Khare, and I am Vice President of JB Chemicals. I take this opportunity to welcome all the doctors, fraternities who have joined us for this wonderful webinar today evening on manifestation of COVID-19 and novel therapies available. So we have eminent speakers today in form of Dr. Brian Pinto. Uh, Sir, Dr. Brian Pinto, he's head of cardiology and director cardiac cath lab at Holy Family Hospital. He's also an intervention cardiologist and attached at Bridge Candy, Hinduja Healthcare, and Safi. Along with the uh, Dr. Brian Pinto, we have Dr. JP Jadwani. Sir is MD Medicine, Senior Consultant, Department of Cardiology and Medicine, in charge intensive care units of Holy Family Hospital, also attached to Lilavati Hospital and Hinduja Healthcare. Along with them, we also have our third eminent speaker, Sir Dr. Hemant P. Thakkar. Sir is a eminent physician practicing in Mumbai. He is a leading cardiometabolic specialist and has more than 3 decades of experience in this field. In his current practice, he gets along with Bhatia Hospital, Bridge Candy Hospital, and also at his private clinic in Chowpatty, Mumbai. So I'll request today, uh, let's start with Dr. Brian Pinto, sir, and then the eminent speakers can take up. So I'll request Dr. Pinto to take that session, please. Thank you.
Thank you, Vikas. And let me thank JB Chemicals at the very outset for having given us this platform. Let me welcome my two co-speakers and co-panelists, Dr. Hemant Thakkar from the southern end of Mumbai, and Dr. Jadwani, who is in the Bandra area with me. Both of them are giving you a wonderful namaste, namaskar, which I think even Donald Trump has started using, the Indian way of greeting. I must say right at the outset that this is something which none of us have ever expected. You know, I think it's been, even when my mother speaks to me, she says, in my 90 years, I have never seen something like this. So I think all of us who, as Bill Gates puts it, this is the first modern pandemic. Why do I say modern? Because we did have a pandemic 102 years back. It was called the Spanish flu. But let me give you a little history about the Spanish flu. It really did not start in Spain. It started in the trenches of Britain and France, where they were fighting the First World War between 1914 and 1918. And they did not want to say that they got it. So when it spread to Spain, it actually got called the Spanish flu because Spain was the first country to declare it. It came to Mumbai via the docks. So many of the people in that area of Ballad Estate were the first to get it. And then via the train system which the British had developed in India, it spread throughout India. And let me tell you that it consumed 50 million people in the world in a population which was not more than 1.5 billion at that time. And 14 million people died in what we then called British India, which means that India had the largest mortality at that time. And mind you, we must take care this time. And that largest mortality knocked off 5% of our population in 1918. We had the plague also that happened a little before that. And lots of people in the 1890s died of plague. So India is not new to epidemics, but this is the first modern epidemic. And as Bill Gates states, no one who lives through this will ever forget it. The pain is immense to all sections of society. The rich, I will say, on top have felt it. The poorest of the poor, like the migrant workers, have felt it. It's more than a world war, in my opinion, because we appear to be on the same side, but we are really not on the same side. We are all going through a storm, but we may be in different boats. The migrant workers are in a different boat. We doctors are in a different boat. The consumers of medical services are in a Pharmaceuticals are in a different boat. The wealthy are in a different boat. So we are in the same storm, but we are in different boats. And this is a situation in which we will all take maybe more than 10 years, in my opinion, that we will take to come through this. So I'm going to now ask my two panelists over here as to the presentation of this disease that has hit us. You know, we were running around in December. I went to all the parties in December, Jan that came up, you know, and it was only, I attended the Bombay Gymkhana day in March, on March 7th, I remember. And Wuhan was already reeling. Did we not see this coming, Hemant?
Actually, what you have described is absolutely right. You know, we should have read the warning signals blowing from the east. We thought that this is going to be another SARS or a MERS, which will float around, knock on our doors, and go away.
Absolutely.
But this was coming, and we should have read it much earlier than when actually we decided to take action.
So who do you think read it well?
If you ask me, I think South Korea read it brilliantly because South Korea realized that there is something more to this. This is not a routine SARS or an avian flu or a bird flu. So they quickly went into lockdown, they quickly went into testing. And believe me, they were the people who manufactured the kits indigenously and immediately started testing, which is something, you know, again, what Brian said, I'll tell you, 2nd, 3rd, and 4th of December, I was in South Korea for the International Diabetic Federation. And I was, you know, I'm jealous. I've never been jealous in Japan and America and England, but I was jealous the way South Korea has evolved.
Progressed.
They have progressed and they are miles ahead. I had to go from a domestic terminal to an international terminal. Their mechanization, their intelligence, their courtesy, the safety. You can walk on the road at 1 o'clock at night with two phones, a full wallet, and a lady carrying a bag, and there is no problem.
Yeah, so let's get, you know, I think the other country which actually has not got mentioned because we still don't consider it a country is Taiwan. And I think that is very, very important to notice because they've had only 450 COVID cases and only 6 deaths. So they have done it as good as South Korea or even better. Germany from Europe has possibly been one of the countries. But now, Jay, just tell us about the presentation of this disease. Do you only get a respiratory presentation or do you get many other ways of presentation?
You see, initially we all thought that the disease is presenting mainly with the respiratory symptoms, but as the time is passing by, the disease is evolving, our understanding is improving, right? Okay, and now we have realized there are various presentations of this disease. If we talk of the symptomatology, if we talk of the symptoms, still the 80% of the people will present with you fever. All right, okay, and then the other common symptom is the cough. Then the newer symptom, what we have realized in almost about 15 to 30% of the patients, which we did not know before, was a sort of a people are not able to realize the smell. People are not able to test the food, right? Okay, and this has become an important symptom, right? And very often, I remember 3 days back or 4 days back, a old patient of mine called me and told me, "Doctor, my father just can't smell anything suddenly. He's just not liking the food, anything. His liver enzymes are normal." I said, "No, Baba, please get the COVID test done." And the old man was positive. So we all had to, in the current scenario, irrespective of the symptomatology, if somebody is running a fever, somebody is not feeling well, I think first worry or the first possibility is that we must make sure that we are not missing out the COVID,
Like
right? So we
previously,
have
we
to
used to
keep our
talk,
eyes open.
like we used to talk about tuberculosis previously. No other diagnosis, think about tuberculosis.
Tuberculosis.
Hemant, have patients presented to you with stroke or with myocardial infarction or with diarrhea? Are these some of the other presentations that have been described? Have you had any of these kind of presentations? Hemant, did you hear me?
Okay, you're asking me?
Yeah,
Yeah.
yeah.
So, you know, we've had patients presenting only with diarrhea, with mild fever and diarrhea. And we've had patients presenting only with severe fatigue and weakness. And they keep complaining of fatigue and weakness. And probably the family physician, in good faith, gives them symptomatic treatment till when they are brought in on fourth or fifth day. They are lying forlorn. And if you look at their saturation, it is 70%. What we call is the silent or happy hypoxia. So I think what began as a respiratory virus, and it is still predominantly respiratory.
Respiratory virus.
You do have the hurt in the throat, and you do have the itch in the neck, itch in the tongue, and you have fever, but you can get GI presentations. You can get cardiac presentations. We've had patients coming in with acute myocardial infarction. The syndrome is ACS. The ECG may be atypical. In fact, one wants to sometimes draw a simile to HIV, where you get atypical presentations and you get different ECG patterns. So we've had cardiac presentations. One patient presented as meningitis, which gives food to the thought, which Dr. Jadwani said, that the hyposmia or inability to taste could be a CNS involvement and producing this kind of picture.
So, Jay, I wanted to ask you a situation when a patient comes to the emergency room, you know, how and he's coming over there. How would you triage him? You know, triaging the patient is very, very important. They've come in. He's how would you kind of triage him, send him home, hospitalize him, send him to the ICU, think that he needs a ventilator? How would you put these patients out? How would you
I will
triage
say
them?
that's a very good question, but it's a very, very broad question, right? Okay, and now suppose, as you said, we are dealing with the patient in the emergency room. Our thought process, our decision making will be different. Once the patient is admitted to the ward, then how do I take him? It will be different. Once the patient is in the ICU, how do I take it? It will be different. So I would like to divide this question into three parts. As you said rightly, first we see the patient in the emergency room. So what is the thought process? Whether patient has got a problem or no problem, whether I need to admit or not to admit, or should I send him home? Right? If the patient is looking comfortable, right? Okay, and he has got no significant symptoms. The most important thing, which is the decision maker, as Hemant said a minute before, look at their saturations. The dictum is very clear. Anybody with a low saturation, by low saturation I mean anything below 94%, should be admitted, right? Okay, and all these cases who are breathless, have got a tachycardia, right, running fever, not looking comfortable, they all should be admitted, right? Once you decide the patient is to be admitted, then the question will come whether we admitted to the room or should we shift them to the ICU. For example, I have decided to admit this patient to the room, all right, and then my workup will decide how long I keep him to the room or should I shift him to the ICU. All right, I think if you want, I can take it up here only, or when we come to the investigation, then we divide accordingly, Dan, right?
No, I want a clinical position right now. I don't
Right,
want
right.
this.
Brian,
So
Right.
I
I'll
want,
ask. No, so Hemant, I'm going to ask you this. The
right.
patient has presented to you in the emergency room. You have done his oxygen saturation as the first test because you can just fix it on his finger. You see, I'll tell you that this patient saturation is 88%. I'm telling you that his respiratory rate is 22. I'm telling you that his heart rate is 100, okay, 98 to 100. I'm telling you that he's running 99 degrees temperature. Now, where would you send this patient? He's 65 years old and he's hypertensive. His blood pressure is well controlled and he's mildly diabetic, but he just needs one tablet. He's not like a severe
So,
diabetic.
this,
I've now given
So
you
it is a
the whole
good background, yeah.
profile, a good background of a patient.
so
What would you do?
you've given a classic viremic background where he has low grade fever. He has two risk factors, both are mild, but he has a low saturation. Now, by definition, anybody who is under 90 has to be admitted. So your question is a sine qua non. But since you have so many people attending this seminar, I think I need to bring in one point, which in as much as it is clinical, it is medico-legal. I want to tell everybody on this webinar that if you have a patient who is asymptomatic or who is mildly symptomatic, who is able to do his day-to-day duties and has a saturation of more than 92% or 90%, you cannot admit him. The Bombay Municipal Corporation is avoiding and will unnecessarily ask you too many questions if you admit. So today, if you get a phone call that I want to get admitted because I have COVID positive, it is not like the dengue days when the patient would ring up and say, "Sir, I am fine, but my dengue is positive. I want to be admitted." So only if you have a parameter of poor saturation, or if you have a parameter with great comorbidities, if you have uncontrolled diabetes, you have cancer, you have chronic renal failure, then you might admit the patient. And your question was asked to me in triage. So in triage, I would want to send 6 or 7 out of 10 patients home because they don't need admission. My hospital bed, even if it is not in ICU, just for giving high flow nasal cannula oxygen, has to be reserved for symptomatic needy patients.
So I take that point very well, but I think my patient, which I sent to you, would get admission
Admitted,
Yes,
yeah.
because
because he's
his
Initial, yeah.
88%,
his saturation is 88%.
and he has
Now,
risk
and he
factors.
has
Risk factor.
the risk factors. So on the other hand, you get a patient now, Jay, who's
Yeah,
come to
yeah.
you with a ST segment depression, and he's complaining of mild chest pain, and he has got a troponin which is HS troponin which is 60, huh? And the normal value, I'll tell you, is up to 35 in males. He's a male patient. His troponin is 60. He's complaining of mild chest discomfort. He's not sweating. His heart rate is 90. His blood pressure is 110/70. His previous blood pressures used to be 120/80. He's on a blood pressure tablet. He's on telmisartan. And how would you take this patient on? His COVID test is not available to you immediately. He says, I feel feverish, but you measured his temperature. It is normal. And you have this particular presentation. How would you take him on?
Fine. As far as the history is concerned, this guy has got definitely the chest signs. He's got a symptoms. He's pointing towards angina. His troponin is positive. With ECG is showing ST changes. He is definitely acute coronary syndrome with a troponin positive. So this guy has to be admitted, right, to the intensive care unit. We must sort of start our traditional medications for him because he's not the guy who is having a no pain, no discomfort. He's come incidentally. ECG showing changes. He has come with the symptoms.
Are
Yeah.
you going to stop his telmisartan?
No, no, I'm not going to stop his telmisartan. As per the new information available, if somebody is on a ACE inhibitors or ARBs, we should not stop it because
Correct.
this is rather more protective, right? I will
And
continue that
now
medications. Yeah,
let me say he was not on telmisartan, but he is come in heart failure. He's ejection. You took quickly from your Jay. You have to shift your echo, huh?
yes,
Now you have to start doing it from the right side. Okay.
right, right,
You
absolutely, absolutely, you're
so
right, correct,
you've gone on the right side and you just screened him and you've seen his
right,
ejection fraction is 30%. His mitral valve is not leaking. Okay.
right.
And
But it's,
no, I'm just giving you the
yeah,
picture. His
yeah,
EF
yeah.
is 30/35. He's not, his previous EF, you have done it about 3 months back. It was normal EF. He's come with all these symptoms. Would you now, I'm asking you, put him on an ACE inhibitor or not?
Oh yes,
Or would you put him on Vimada also?
oh
Would
yes,
you?
oh yes.
Yeah.
You see, when the problem started, when the Wuhan episode was there, everybody thought that because of the etiology, right, because how the virus enters into the cells, they were all worried about the use of S inhibitors and RBS. But it has been proven beyond doubt, these medications are very, very useful. They prevent the morbidity and mortality. So we must continue. If the patient is not on it, we
ACE
must
one
aid it,
virus.
right? Okay. And the only reason for me to stop it or not to start it will be only if there is a contraindication, like
Absolutely.
if somebody got
Absolutely.
acute kidney injury, somebody got a hyperkalemia, or somebody got a hypotension. The patient, the scenario what you described, Dan, I think he deserves and
Very
needs the
important.
army that we must start that and give him all the possible
Brian,
benefits.
Go ahead.
I
Go
have a
ahead.
paper to tell you about.
Yes. Yes.
Some of the guidelines have correctly said what Dr. Jadwani said. If a patient is on ACE inhibitor or ARB, you definitely don't stop it. But if a patient is on neither of them and if he comes in a COVID situation, Some books and some papers are saying don't start it because both of them compete for the receptor and you could displace the virus. Now, do you have any? Otherwise, I can give you those two
I know. No,
references.
I want to give you the reference and state that you must start it, because yesterday only I was on a chat with Ferrari, and
Hmm.
Ferrari
Yes.
presented the paper
Hmm.
where he stated, and we'll send that document to you,
Hmm.
where he very clearly said that the virus enters the cell through the ACE2 inhibitor,
ACE2.
ACE2, whereas the ACE inhibitor acts on ACE1. So there is no competition between the virus and the ACE. In fact, he says there is an increased production of this particular thing to block the virus. So he showed a paper. I think it was from Italy or it may be from China,
There
and
is
not
an upregulation.
upregulation. And
Upregulation.
what
Yeah.
really happens is that people who have been on ACE and ARB, even those who were started, showed a lesser mortality than patients who were not on ACE and ARB. So
But
it becomes mandatory for you
yes, I
to
agree.
give the patient, and not to not start, but to start the patient. If he needs an ACE or an ARB, you start him unless there's a
I wanted you to
contraindication.
bring out
Contraindication.
this
Yeah,
point
yeah,
because
yeah,
there is a misconception
yeah,
floating.
yeah. So that we can get into. Now, I just want to take you all through this particular slide, and Hemant, you can tell us. I first want to go from the bottom of the slide, the negative patients. How would you call a patient negative? He's come with symptoms. Anybody can get cough and fever. It's not necessary for you to have. And now with the rains coming around the corner, you'll get other respiratory infections. How will you differentiate them?
So I would look at the middle, the B part of the negative, where a suspected case with two negative tests. Now, we are all clinicians. When you see the patient, remember, don't jump in and do a COVID test on day 1 to day 4 at all. Because if you did that, you're going to get a negative test. It's like an NS1 antigen in dengue, which you should wait to do at least till the third day. So if you have a suspected case and your first test is done on day 5 and it is negative, your next test should be done on day 11. And if that is also negative, day 11 or day 12, then you are a negative case. I don't think now things like history are valid because we have community transmission.
Transmission.
So
And
how do you then, a guy comes in, he's got an acute coronary syndrome. We do one COVID test and we take him in. I think that is not adequate to tell
Not
you that
adequate. Not
he
adequate.
absolutely.
is COVID negative. No, it's not.
But Brian, you have no choice.
You have no
You are
choice.
doing the COVID test to complete the protocol.
Yeah, no. What I'm saying,
So
basically, for your own protection
You
and for
have
the
to
protection.
assume all
patient
patients
is
are COVID
positive.
positive until proven by this
Otherwise, yeah.
criteria.
Yeah. So
You see,
how?
Brian, unfortunately, even when we do the test, where the results are,
Yeah,
it
yeah.
takes a lot of time, right?
Now tell me one more thing about this IgG and IgM antibodies. How do you take it as a part of community-based infection? I'm not going on to this probable and suspected case now. Let me talk to you about the IgG and IgM antibodies. How do you all assume that these will help us in the future?
It is just like the dengue. I want to put it because all our viewers have treated dengue.
Dengue.
Your IgM starts becoming positive by 6th day in dengue. Here it starts becoming positive by 8th day. And it tapers off by 18th day in dengue and 21st day here. After which the IgG, the delayed antibody response comes in. The only problem is the kits that we have for testing IgG and IgM. It would make life very simple if the ICMR were to validate these kits and get the kits of appropriate sensitivity, because then you could stop anybody on the street and say, let me do your blood. In 10 minutes, you could tell him either you have had infection if you have IgG, or you are having and you are in infective phase if you have IgM, or you never had it if you do not have either of the two. But again, sensitivity is very important, as is specificity. But we are waiting. I'm sure in times to come, when there is more infection in the community, rapid antigen antibody tests will come in.
So now I want to ask you about cardiac, a little bit about cardiac. How, Jay, would you think would be the presentation of these COVID cases? I think they can present to you with acute coronary syndrome, they can present to you with heart failure, and they can present to you with arrhythmias. These are the three major presentations that you can have, besides myocarditis, which has not been so common in this particular setting of COVID. Myocarditis has not been so common. The other thing that they can present to you is with this thromboembolism, which could be in the small vessels, or which could be as far as the venous thrombosis that occurs as like DVT and things like that. But are you seeing patients who are presenting now? There's a Lombardi thing where they have shown that the incidence of sudden cardiac death may not be the incidence, but patients dying of sudden cardiac death has increased remarkably. Maybe because patients are hiding away from the hospitals. That's what Ferrari had to say, that so many of them, because we told them on television, if you get mild symptoms, stay at home, do not move to the hospitals. So are we going to see a sudden increase in this, sudden cardiac death, in ventricular arrhythmias, and in cardiac syndromes? Because now we have, in addition to all the other risk factors, we have a pandemic on our heads.
You see what is happening, Brian, as you said rightly, because of the COVID situation, who are so-called non-COVID patients are suffering a lot. For them, the admission has become very, very difficult in any hospital. The suffering of those patients, we all are aware. They have to keep on jumping from A to B, B to C, C to D, remaining in the ambulance. And at the same time, there is a fear also in the patients of mind. Oh, I have got a heart problem, but I'll wait, I'll observe. If I go to the hospital, I may get a COVID, right? So they are apprehensive also. And that's the reason possibly we will be seeing more of the heart failures, we'll be seeing more of arrhythmic deaths, right? Okay. So definitely so-called sudden death, which are the patients who are actually dying at home because of not coming to the hospital.
We are missing that golden 2 hours, I think. In many patients, we are missing
where we could have helped them, right?
Yeah.
Those patients are not coming to the hospital. Even if they are coming, poor people are not getting straight away the admission. That's the one part, so-called the non-COVID. But as far as the COVID population is concerned, now the current philosophy has been, okay, the day by day, the pathophysiology is evolving. And we all are also understanding what they have come out, right? Like I was going through the very recent paper of the fifth itself from a very big group, right? Okay, of the our Dr. Foster, right? Okay, he presented a case that this is basically a vasculopathy with a prothrombotic state. What he said very clearly, and he has shown very clearly, in the COVID patient, there is a severe endothelial dysfunction. All right, and they have a abnormally high prothrombotic state. They have a very, very high propensity for the thrombosis, which is in both, as you said rightly, Brian, in the micro vessels as well as the macro vessels. Macro, it involves both, right? Our the small size arteries, medium size arteries, even a large size arteries. And they have shown in this COVID situation, and as the duration of the patient increases in the ICU, the chances of thromboembolic episodes, whether we talk about venous or talk about arterial, both increase very, very high.
So I think thromboembolism has become a major issue, and maybe one of the pathophysiological mechanisms for creating many of the complications, even the lung complications. That's the reason why we have been told, even if you keep the patient in the room or you keep him at home, you tell him to lie in the prone position. That improves his saturation a lot, because much of the drainage occurs in the prone position, because all of it is not a pneumonia. Some of it, or major portion of it, is this thromboembolism that is happening.
Right.
And so Brian, before you go away from the cardiac history, I want to draw attention to the fact that we are getting acute myocardial infarction and strokes with normal ECGs.
Normal.
And this is because of a phenomena called angiitis.
Okay.
It is an inflammation of the ANGI, of the wall of the blood. It's an inflammation.
Correct.
And that inflammation causes a normal ECG. There is no circulatory dysfunction.
Right.
It is an angiitis which is causing middle cerebral artery, right coronary artery, and other things. And that is the reason.
That's another problem. And now there's an increase also in Takotsubo, because Takotsubo is coming up with the anxiety, with the stress, with the other things,
Right,
where we
right.
used to see it very uncommonly in females, where they had normal coronaries, but there was a dilatation of the apex of the heart and the coronaries were normal. They would present in cardiogenic shock also at times. Now, the problem is that when we get cardiogenic shock patients now with COVID, it's really difficult to treat them because, how do you put so many people onto a single patient of cardiogenic shock and, use up your, we do not have like the West, a large number of, people to help in the hospital, and we don't have those kind of hospital beds. So this is the possible mechanisms, as all of you have
Mechanisms,
pointed
right?
out.
Yeah.
The cytokine storm that can occur on the 7th, 8th, 9th day, as all of you all have told us, the arrhythmias, the acute coronary syndrome, the myocarditis, all of you have said all of this. And this is the metabolic activity, the whole thing that's going, the virus coming in, inflammation, the macrophages, the myocarditis, the ILC, the interleukin C, and then the plaque rupture, the plaque instability, the microvascular, all you have pointed out everything, the microvascular dysfunction. So almost everything that can occur
It's
in an
possible,
ischemic
yeah.
heart and an ischemic coronary or ischemic cerebrovascular situation can occur with COVID. And this just heightens the whole situation. So now, here once again, you can see that the suspected and the suggested pathophysiology for viral infections is this cohort of patients who are presenting. They may present to you with hypotension, with tachycardia, sudden cardiac death. And this may be a big problem, actually, that you can see. We all know, Jadwani, that, when infections occur, like pneumonias occur, viral infections occur, there's an increased incidence of stroke, there's increased incidence of myocardial infarctions. In fact,
Infarction.
even in the Hurst textbook and Brownwald's textbook, one of the clear precipitating factors for an MI is infection, pulmonary and infections all over. So now let us look at this particular slide and ask you whether heart problems caused by the virus itself or the byproducts are the critical unknowns. And what do you think about heart damage as being a very severe kind of situation and the heart failure kind of situation coming into our lives? Are we going to see many, many more heart failure patients? Jay.
I think definitely the incidence is going to increase, right? Okay, there will be two kinds of a patient here. One, the group which we already had a heart issues, right? Suppose he had somebody a myocardial infarction, had a LV dysfunction. His problem is definitely going to increase further, and they have found. And the other thing is the because of the severe myocarditis, right? Okay, there is definitely a damage to the myocardium also. And at the same time, they have come out with a theory that possibly the endocardium itself is also getting damaged, right? Okay, the inner lining of the heart itself is getting damaged, and that further leads to so-called a non-thrombotic ischemia, right? Okay, and that is increasing the even clot formation to the myocardium, right? Okay, so in short, I feel because of the various reasons, right? You can have an excessive inflammation, you have a cytokine storm, you have an increased propensity for the thrombosis, right? So-called a prothrombotic state, and at the same time, so-called a type 2 myocardial infarction, right? Okay, when there is a disparity between the supply and demand, right? Okay,
So
and because
do you think, see, we are seeing less number of cardiac patients, Hemant? I do not know whether that's the same, but we
true
had
or
a
not,
we
yeah.
had a big we had a big conference about it from all over the country, and we spoke even to our people in Italy and in Germany, and they also said that we are seeing less number of patients reporting for myocardial infarction and for acute coronary syndromes. Though we know that this should actually increase because of this virus. Do you think there is an underreporting of the cases as well, Hemant?
See, remember one thing, we are forgetting that out of 100 patients, only 5 patients die. So when these 5 patients die, if you segregate them and compartmentalize them, the final common pathway is massive inflammation and invasion into all the vital organs of microemboli and inflammation causing the cytokine release of interleukin and other things. Now, it all depends in which patient it is the coronaries which get inflamed, in which patient it is that you get inflammation of the kidneys, of the respiratory system. But remember, since there is definitely a very high respiratory endothelial cohabitation of the COVID-2 virus, the lungs are the first to get affected,
Target, yeah.
and then everything goes to the lungs. So probably the heart is partially ignored, but then everybody thinks it's a sympathetic issue where you get low EF and you have high troponins and anti-proBNP and D dimers and everything put together. So I think we should not split hair as to which organ, because the therapy is going to be the same:
Okay.
anti-inflammation treatment and prevention of microemboli, and then antiviral action.
So before I go to you, what are the tests, Jay, that you would like to do in a moderately ill COVID patient who comes to you? What are the basic blood tests besides the normal ones? Like you would, of course, do the CBC.
Right, right,
I would
right,
this thing. But what other tests besides the
right,
panel that you would
right.
now include to your COVID patient?
Right. When I'll slightly modify the question. For example, a patient is in the ward, right? Okay. And then I want to preserve my ICU beds, right? Okay. So on what basis I should select those patients who are on the ward who are likely to deteriorate? I'll just give a slight comparison here, as we all of us seen a pulmonary embolism, right? A pulmonary embolism which comes in a very massive pulmonary embolism, hemodynamic collapse, no question, goes to the ICU, is to be treated. And we know there are a other group of the pulmonary embolism cases which look very well to us, but about 30% of them can deteriorate coming 24 hours, which we designate now as the intermediate syndrome, right? Okay. But now, is there any something like this in the COVID situation? I think possibly yes. What the philosophy is going world over now, how do I save my ICU beds? In other words, when I have admitted a patient to the ward, whether I continue to keep him in the ward, or is it that the storm is around the corner? Can I identify that a storm which is likely to come in these patients who are in the room? There, the workup is very, very important. Once the patient is bad, once the patient is in ICU, once the patient has got a ARDS, once the patient on ventilator, is a different ball game, right? You know, he's already in a higher mortality group. My worry is about the normally or comfortably looking group who are likely to deteriorate. Can I identify them? Yes, the just a paper has been published 2 days back only. They said again the mother of all these problems in the COVID situation is also an endothelial dysfunction. They have said, can I identify these cases where I pick up the markers of the endothelial dysfunction? Then I know this patient is likely to deteriorate. So I take it more seriously. So now when I do my routine test, so like I do, for example, blood counts, of course you have to do. So what do you see in the blood counts? We all need to see very carefully, very specifically on the number of the lymphocytes. That's at the decreasing lymphocyte, the lymphopenia is a bad marker, is a negative marker. What they have said is the comparison again, and this lymphopenia is basically reflecting there is a deficiency of the CD4 cell count. In other words, what it is telling us, the CD4 cell count or my simple lymphopenia is telling me that the patient's immunity is going down and down. This patient will have a more activated macrophages, will have a more activated neutrophils. So this candidate is more likely to go into so-called cytokine storms. It is giving me a warning. If this patient is likely to develop a cytokine storm, so I take it more seriously. So this will become a one red flag for a given patient in the ward. Now I look for the other red flags. For example, I do my D dimers in the ward, right? Okay, and they have said very clearly, if the D dimers are more than 1000 nanograms, I should worry. The moment you find D dimers is more than 2000 nanograms or more than 2 milligrams, the mortality is very high. A patient who's in the ward, his D dimers have come very high. I know I should shift him to the ICU because he is likely to develop a diffuse thromboembolic episodes in no time. So this is another red flag. The other red flag what they have given is the troponin, as you said, Brian, right? Okay, the rising troponin, right? The patient who have got a normal troponin, the mortality is almost like a 5%, and those patients who got a very high troponin, mortality is almost like a 50%, almost
70% if they
10.
have cardiovascular disease.
Yes, almost tenfold high, right? So this is a one marker. So what they have come out with a very simple one more thing. How do I monitor a patient? Just do their urine routine. They say these cases, the first thing what you develop, which we all have been ignoring so far, is they develop a nephritis. A very simple test, which is I think good for a country like India, which is not expensive. We must monitor their urine routine on a daily or an alternate day basis. Suppose I see a patient On day 1, urine is normal. And on day 3, he develops a albuminuria. I know he has developed an endothelial dysfunction. If I find he had no RBCs in the urine, on third day he has got a RBC in the urine, I know he developed an endothelial dysfunction. Right? Okay. If he has got a leukocytes in the urine, which was not there, these are the good markers that the patient is having an endothelial dysfunction. At the same time, they have come out with a very simple marker, serum albumin. If you find there is a rapid fall in the serum albumin, or if you find serum albumin is less than 2, then you know all these markers we should put as a red flag. And if I see a patient
I
in the
think
ward,
very good.
yeah, yeah, yeah.
Is serum ferritin also important?
Yes, serum ferritin is a but serum
Very
ferritin
important.
brand I had seen in a lot of cases in our
Would come high when the inflammation has
is
already started
increasing.
going.
It's
Is
not the
increasing.
baseline ferritin, but
No,
the
it's not.
increasing ferritin.
Increasing
You
ferritin
see, but
levels are also high.
I lost a lot of respect for the ferritin because of my dengue experience.
Okay.
I used to see dengue patient looking very comfortable.
Yeah.
But the patient is fighting with me to go home, then I'll do ferritin level. Ferritin will come 18,000, 20,000, patient get worried and will be in the ward. But in the COVID, they have shown very clearly the rising ferritin is again a big negative marker or bad marker.
Yeah.
If a
Yeah.
patient with me in the ward shows all these markers, I must shift him to the ICU. Or a
So-
patient has got all the negatives, I don't need to rush to shift to the ICU.
What are the Hemant? What are the kind of imaging tests that you have been asking for in some of these patients? Are there some of the patients where you ask for echocardiograms or you ask for
So,
nuclei
Brian,
tests? Yeah.
before I answer that question, I want to draw one point of caution.
Yeah.
All the people watching this, we are theoretically telling you everything, but today the media is going to browbeat you when their bills come higher and higher.
That's right.
So, while the ferritin can go up, the interleukin can go up, the D dimers go up, the troponins go up. Remember, you are bedside physicians. I like the idea of looking at lymphopenia and looking at
Urine routine.
CBC. You could do a initial D dimer if the patient comes in on fourth or fifth day, which is when they usually come. But if you keep repeating troponins and D dimers and interleukin markers, anyway, the cost of COVID care is high. So please be careful. But what Dr. Jadavani said is correct. The window between good and bad is very small. So your intensivist has to be on the job to look at saturation, to look at respiratory rate, to look at dropping lymphocytes, and then decide about ICU. Because any which way, every patient who comes in, if the patient has risk factors, which he has, you already start them on low molecular weight heparin. However, now I come to Dr. Brian's question about imaging. I would say the simple imaging is X-ray chest, and the next imaging is CT of the chest. I would not waste my echo machine unless I have a ACS-like picture. Remember, one PPE, one machine exposing a cardiologist going into COVID ward. I have a rule in my ICUs that all X-rays will be done at the same time and all blood collection at the same time. So only one technician goes and finish. It's like a cart
Everything.
on the airplane.
Very
Your
good.
air hostess is serving you
Absolutely
from
right.
1 to
Very,
20.
very good. Very good. Hemant,
Good
I think
point.
that was a wonderful point.
Yeah.
And I think the CT of the chest is the next important investigation, which I wanted you to bring out, because I think there's no point in getting echoes unnecessarily done. They're not really required unless you have a situation where you have an acute and even then, you may do it at the time when you're doing the angiogram if you have to do the angiogram. You don't even have to expose somebody to the echocardiogram, of a COVID patient. Now, as far as I think we've already spoken about ACE and ERB, so we will not go into this. But I want to put one point: the troponin is important. If you get an elevation of the troponin initially, then you follow it up because it can tell you towards a patient who's going to go towards mortality because
Like
the
a
troponin,
prognostic marker.
a prognostic marker, which would be very interesting. Now, I want to ask you a little bit about patients who are. How do patients with cancer, patients with heart transplant, patients with decompensated heart failure, Jai, deal with this kind of situation?
I mean, basically, if they have this kind of a background, they don't do well, to be frank. They are much more susceptible right? Because as it is there, for example, a cancer patient, as
Yeah.
it is the immunologically compromised man, right? And as it is, this virus is further killing your immunity, right? So they are more prone to the complications, right?
So I'm
And
going
they,
to ask you all one question over here, both of you, and I want an answer. How many patients of yours have gone for bypass surgery in this 4 weeks or 6 weeks? How many? I have not sent a single
forget
patient.
bypass brand. I mean,
No,
we
no,
are
I'm
trying
just
to
no,
work
no,
on
I'm
even a
just
routine surgery,
no, I'm just
right?
asking
Simple.
you.
No, you're right. Absolutely right, right?
Hemant, you have so many patients who normally go for bypass surgery, okay? And
So the bypasses have dried up. Corona wins, bypass tails.
no, but we need to understand why this has
Right,
happened.
right,
These
right.
people have
You
not.
see, because
Pe-
there is
pe-
a lot of window period even in the diagnosis itself.
yeah,
Right? Today, patient may be negative. After 7 days, it becomes positive. Means how many people you have got affected, right?
you
And as
know,
it is, the prognosis of the patient itself is also going to be poor then.
even the cardiologist doesn't want to get into the lab today
That's right, yeah.
to do an angiogram or to do an
We
angioplasty.
all know what happened in South Bombay and how many labs and how many theaters got
Theaters,
infected.
right?
Affected,
Got
yeah.
But
yes.
having said that,
Yeah.
I don't want to take the halo of cardiac surgeons away.
No. They
We are going to get herd immunity, and now we are going to operate next month. Whatever happens, your
Whatever
NGOs
happens
will be
then.
back.
may be back slowly. They'll
Ultimately,
be
life
back
has
slow.
to start
No,
gradually and cautiously.
but it'll start cautiously, Jai.
Cautious.
Don't
I'm saying
think,
the same thing.
don't
Cautiously and gradually.
there's going to be a new normal.
That's right.
As
There's
Bill
going to be a
Gates
new
said,
normal.
there's
I
no
like it.
normal. Now look at this. These are ECGs of STEMI mimetics, And the one point which I want to bring out over here is that when you see these ST elevations, normally we would all have jumped and said that this is, I want to put a little caution over here.
Caution over
All
there.
of these may not have an acute occlusion of the LAD or an acute occlusion of the RCA. It may be a situation where you go in and when you do the angio, so test,
Maybe
keep your
normal.
mind open. Some of them may be tough. And the way to sometimes understand this is to look for reciprocal depression. If the reciprocal depression is not there in these patients, have a high index of suspicion that these may not be true myocardial infarction. So you must look for the reciprocal depression that is
And
there.
then, Brand, one more word here. In this situation, I think when you have a strong suspicion and you want to decide whether to go to the cath lab or not, then the echo is useful.
Yeah, useful.
Whether you find any particular coronary artery regional wall motion or it's just a
absolutely
global,
now
right?
the other thing which I want to bring up over here is the fact of how are you, Hemant, today? Suppose an ST elevation myocardial infarction comes to you. I was never averse to giving thrombolytic therapy. Let me tell you, though I'm an interventional cardiologist, if a patient was, let's say, in Holy Spirit and I was at Bandra, or the patient was at Saifi and I was at Bandra, I would say thrombolize the patient if he's come within the first hour, because it will still take me 1 hour to reach there and another some time to start. So are you all open? Let's not talk about Western literature. In Indian literature itself, we have found that PAMI is not as common as it occurs in the West. So are you all open to thrombolizing patients? Jay, are there some risks of thrombolizing these patients? And what, because we have seen now that COVID positive patients may not have a true thrombosis over there. So
I have thrombolized 4 patients in the last 5 weeks.
Yeah.
Remember, they presented with acute myocardial infarction, ST elevation with reciprocal changes. In shock.
Yeah.
There it is important to recannulate and open up the vessel. Having said that, all these 4 went home quite well.
Okay, so you haven't done an angio for that patient after that. Maybe you didn't want to do it.
The
maybe
patient
the
didn't
patient
want to
do it. Whatever. But normally you would have suggested an angio to these patients. Normally, I'm not talking about this COVID time. So we have possibly changed our strategies also, to treat these patients. And we may have to really once again re-strategize and re-understand how we are going to treat patients with COVID. For example, Jay, if you were to get a patient, like we have started this eye care movement, in Bandra, and it's going through in us, we would make our heart marshals resuscitate a patient. We've resuscitated patients on the road, in the gymkhana, and all that.
Successfully,
Successfully, we have taught them how to give these DC shocks and, how to give these the cardiac resuscitation, CPR, and how this cardioversion occurs. But how would you do it now in this COVID era? How would you give CPR in this COVID era?
This is not easy, Brian. It's not easy, right? Okay, it's not
Definitely
easy.
not
Yeah.
mouth to mouth.
Mouth,
No,
definitely, as it is,
see,
it is out. That's
that's
already
out.
out.
Mouth
Yeah,
to mouth is out. Mouth
already
to
out.
mouth,
It's
we have
only,
stopped it.
yes, yes.
No,
You
that
see,
is
during
stopped.
the
But
during
there's
this,
an aerosol during the
yes, during
cardiac
the
compression.
resuscitation, there is always an aerosol, and
Aerosol.
aerosol is the most worrisome thing, to be honest. Yeah,
Yeah,
okay,
yeah.
yeah, yeah. And I think,
So,
as we were
That is
trying to
why
say
we are
about
not
the
nebulizing.
yeah, yeah.
Nobody is
no, no,
allowed
no
to
nebulizer.
nebulize.
Only whenever you need a nebulizer, you use the inhalers.
How
Right?
do you all do you all use any non-invasive ventilators over there in your COVID area, Hemant? Are you all using, because those
If a high flow nasal cannula does not work,
Work, you have to intubate.
intubate the patient or put
okay?
him in a prone position, because an NIV is going to generate a lot of
A lot
aerosol.
of aerosols.
Aerosol, correct.
Not a good choice. And not only that, once they are not better with the high flow oxygen, they
Yeah.
usually deteriorate very rapidly.
So
Yeah.
can the two of you look at this particular slide over here of ER excess, and tell us how you all would look at this triaging? I think we've already gone through all of this, and so we'll
I
go
think this
ahead.
is
Yeah,
perfect.
that's
So
Next slide.
let's go to the new therapies which we are talking about, the antivirals. Something about the antivirals I want to ask you about, and here is where I'm going to ask Jay about remdesivir. Is there so much data on it that they made it available in the United States of America, saying that it's going to cure this particular thing? What is your view on remdesivir?
You see, remdesivir is an antiviral drug, right? Okay, and this is was available to us before also, and there are few trials in which they have found the data is not very robust. Just the trend, the little positive trend, not a robust data. They found that you can cut short the duration of illness by few days. That's it. Basically, it has not changed the mortality in a big way, right? The mortality change was not significant, really, right? If you have said, for example, when you that was a absolutely p value was absolutely not significant, right? So, but at the same time, I don't know whether there is, as we know, in medicine, sometimes politics is also there. If you see the company which is producing this antiviral drug, is the same company which is involved with the virological institutes also. I have no answer, but at the same time, the data is not very promising. But at the same time, none other drugs have also shown any advantages. So if I have to use anything, I'll prefer to use this drug. The dose is about 200 milligram on the day one and followed by 100 milligram daily for about 10 days. The duration is about 10 days, right?
It's an intravenous drug. So
It's an intravenous drug.
I would like to ask Hemant about the next drug, which is a Japanese oral
Molecule,
drug called favipiravir. Have you got, it can be made by, you already told me the last time that it is manufactured here in India as well. But is it a possibility that this drug could work? Is there any data for it?
I think the ability of remdesivir and the ability of favipiravir would be more or less similar. As Dr. Jadavani has said, one drug has been trumpeted from the West, and now we have this other drug from the East. I classify both of them as nucleotide analogs, and they are going to work or not work in the same fashion. The papers on remdesivir are a little more, but all that they do is instead of 10 days hospitalization, they reduce it to 7.
6 to 7
I'm
days.
sure favipiravir, but I would choose favipiravir for India because it is cheaper and it is
oral.
oral.
Favipiravir, definitely.
Yes.
Now tell me about hydroxychloroquine and chloroquine. What are your views, Hemant, on this particular agent?
I am not using chloroquine. I am using hydroxychloroquine because hydroxychloroquine, again, I've been shouting in the media, is not an anti-malarial drug. And hydroxychloroquine has been safely used by my collagen and arthritis patients for 15 years, by my diabetic patient for 5 years, and I've had no side effects. So cardiologists, please excuse we are happy to look at our glass 99% full and not 1% empty, which has been again trumpeted about cardiac side
So
effects.
I don't think
Hydroxychloroquine.
it's quite a safe drug, as you mentioned.
Yes.
We have not been using it. It's
Correct.
also being used
Correct.
for diabetes amongst your
Correct.
physicians.
And it hardly has
yeah,
the G6PD problems.
yeah,
So hydroxychloroquine is safe.
yeah.
As the medical dictum is, if you can't do good, don't do harm. HCQS does no harm.
Yeah, I think
You
it is
will-
unfortunately, I think people have mixed the chloroquine and hydroxychloroquine. They're two different drugs,
Drugs.
and hydroxychloroquine has much less side effects. And we were never doing QT level testing QTs for hydroxychloroquine when we started it for rheumatoid arthritis or we started it for diabetic patients. So I don't think unless you have a structural heart disease or you have previously a QT prolongation that you need to test everybody.
Brian, I
So,
would like to take it a little bit more further here.
yeah,
Same, 2 days before, a big series has been published by big, I mean about 1,000 patients from the France.
it is actually from the south of France,
Yeah.
and that's a big this thing. But it
Almost
was
1,000 plus, 1,000
he
plus
has,
patients.
he has
Yes.
shown a benefit over there from
Lot
Marseille.
of benefit,
Yeah.
and hardly any side effects, right?
Yeah.
Okay, and for a country like India, I think we must sort of propagate it more,
Yeah.
right? Rather than trying to worry about the QT interval, right? Yeah.
Yeah. So, but basically, the data, though it has not been a placebo controlled or whatever it is,
But
the
given
study,
the situation, it's
it
whatever
it it
possible we've
it,
done.
it can be used. The ICMR,
Yes.
of course, have given guidelines to use it in
Yes.
medical healthcare workers, to use it on a once a week basis. That may not be, having a lot of data with it, but I think some of our medical healthcare workers are using it as 400 milligrams BID for the first day, and then every week they're taking 400 milligrams.
As a
And that's how
prophylactic.
they are going on as a prophylaxis. So this is the chemo prophylaxis, and this is what we have looked at for HCQ. This is the next drug. Any one of you have any information on it? I would like you all to go ahead.
I mean, personally, I have never used it, but it's basically an anti-filarial drug,
Yeah.
right? And whatever I've been reading in the different groups, one of the groups has the drug is given as 6 to 12 milligram per day for about 2 days.
Okay.
And one group working at Rajabadi Hospital has reported good results, Brian. I have no
Okay.
further experience personally,
Okay.
really. Yeah.
Okay. Little bit about convalescent plasma. I think
Yeah.
this may have a role in the future in very sick patients. So these are antibodies basically. If you're
These are
using
antibodies,
plasma,
really. Yeah.
these
Yeah.
are antibodies, and there have been some trials that have gone on, and this may give us some benefit, but there has to be many more
Answers are
trials. So
still not there. Yeah.
answers
Yeah.
are not there, and
Not there yet. Yeah.
would be still these are used in critically ill patients. Now about the vaccines, where are we from the truth? Everybody is touting a vaccine.
You see, I've been talking to somebody else, and they said, yes, my friend wanted a child in a hurry. So I said, you cannot have a child before 9 months,
Yeah.
right? Okay, the same way, when you are in a hurry, still you can't have a vaccine. It
Yeah.
takes its own time.
Yeah.
Right?
Sorry, I got locked out for
Yeah.
some
Yeah,
time.
yeah. I
But,
think
yeah.
Hemant has got locked out, looks like. Yeah.
Yes, we get him back.
Now I am back.
You're back,
Okay,
back. Okay,
okay.
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 We were just talking about vaccine, Hemant, right? Okay. I mean, vaccine is going to take its own time, whether we
Oh, yeah.
like it or not. But at the end of the day, vaccine is going to be the great and the final answer for us. But till we get a vaccine, we have to think of other things like herd immunity and other things. Let's see, Hemant, what you have to say.
I think herd immunity more than vaccine, because where is the vaccine for dengue? Where is the vaccine for
HIV
H1N1?
and one.
Our vaccinators are not of the type of Hafkin and company. Dr. Hafkin was of a different breed. We are trying to make vaccines in a super fast track fashion. I hope it works. But until that happens, I'm sure more than 30% of us will have antibodies positive and herd immunity will come in.
Yeah.
And we will be living with corona. And that's what
Okay.
I pray, that corona will be amongst us and not against us.
Okay, so now what we'll do is we'll go into the question answer session. I think we can stop at this stage. We'll talk about anticoagulants very quickly. What would you all say to patients if they come to you extremely sick? There's the Mount Sinai protocol. Are you going to put your very sick patients, Hemant, on anticoagulations? Are you going to send them out on the NOACs? What is your thought process?
So very good question. If I have a patient coming in on 5th or 6th day with shadows in the lungs and with low saturation, I do his D-dimer on entry. I put him on low molecular weight heparin depending on what his dose requirement is. And if he settles down and is going out on 14th day, maybe I'll give him a dual antiplatelet for a while. I may not give anticoagulants because our patients are not able to follow up in these lockdown. Ideally speaking, they should be on NOAC.
NOAC couldn't be a good answer. You know,
Yeah.
you can put on
You
NOAC.
see, question is not only here, Brian. Question is slightly different now. It is beyond doubt that all of them will need so-called a prophylactic. The question is not that are we happy with the prophylactic dose or we are looking for the therapeutic dose.
Right.
I think we are looking for a therapeutic dose in all these cases now.
Correct.
The person who is little critically ill requires
Yeah.
the therapeutic dose provided there is no contraindication.
Correct.
That's
So
it.
I think,
maybe,
you know,
maybe
but
2
I just
weeks
want to,
after discharge also.
I don't think, you know, if you have a very critically ill patient, it may be a better idea to put them on unfractionated heparin.
Because it has got some
Because it has got some anti-inflammatory activity and it holds on to the spikes of the coronavirus.
Yeah,
you know?
the spike.
So therefore, when they're very sick, maybe that, then the anticoagulation like enoxaparin, and following that on discharge, 2 weeks of epaxiban or rivaroxaban can be the treatment.
But not more than that, for the simple reason that the antigen goes away.
Yeah.
You don't require a longer dose.
Yeah. So short term. Now, herd immunity, as Hemant said, is going to be the answer in future. So now I'm going to thank both of my panelists for the discussion, but we can't stop over here. There are many questions. We need to take some of them at least. One of the questions is, what would be the laboratory investigations outside of range that would indicate a possibility of COVID infection? So, Jay, I think you already had said that, but you can quickly enumerate.
You see, by and large, to start with, there are no leukocytosis. Counts are normal or no normal, and look at the lymphocytes.
Yeah.
A lymphopenia or a progressive lymphopenia is a good marker, which has no cost really.
And you said the urine. Look at the urine
and
also.
look at the urine will tell us if the patient is going to get more complications or likely to get complications.
Do the
CRP.
Does the transaminases go up?
Yes, mild SGOT elevation can always be there like any other viral illness.
Okay. Any role of antibiotics, Hemant? He got locked out again. Jay, any role of antibiotics?
Antibiotics, you see, by and large, once their immunity is down, they are prone to the secondary infections, right? Okay. And the one, yes, most of them will need an antibiotic, right? Okay.
Yeah. The next question is, will this settle in India? Hemant, you are the man with the tarot card. Will this settle in India in this year? They're asking you. They specifically marked it out to you. I'm not joking.
I think we are doctors, not Jyotish.
Yeah.
But I am optimistic that if everybody cooperates and does not break the law, including doctors and rich people, then it should settle in this country.
Should COVID test negative, CT chest conclusive? What would you do? Suppose you had a COVID negative, but the CT chest showed you infiltrates.
Treat him as a COVID positive.
Treat him as a COVID. Okay.
Because the sensitivity of the CT scan is much higher as compared to the test.
Okay. In family practice, fever, nausea, loss of smell, diarrhea, high index of suspicion. Is that true?
Yes.
Okay, I think that is yes. BMC insists reference of all fever patients to fever clinic area. They will decide. Do all patients should go to if they've got fever, go to a fever clinic? I think that's right.
That makes sense today's time for the prevention of the healthcare workers rather.
Yeah. The next question are, what are the chances of a false positive PCR test?
No, there are no.
No false positives? No, Hemant?
No. For COVID test, there are no false positives so far.
Yeah. Is it advisable to start ACE and ARB? We have already answered that ACE ARB question. We said you can start it. You know, for general practitioners, how do you differentiate normal respiratory infection from COVID? This is the question.
Dr. Hemant?
I think he's blocked out again.
Okay. What actually is very, very difficult to answer this question clinically. My humble suggestion will be take all these cases as a potential COVID, right? Okay, because today's time we had to take it like that only. That is important from the safety point of view of the patient and your own safety.
How do you differentiate pulmonary edema from COVID-19 symptoms like cough and breathlessness? It's a very difficult time sometimes. If
Fine.
they have both, it may not be easy to differentiate.
Can be both.
But-
Anti-ProPNP will be a good help.
Yeah, but
Right. And
anti-ProBNP can be
ultrasound of the
elevated.
yes, ultrasound of the chest. If some good guy you got available to you,
Yeah,
if
but
you see the situation where USG chest can be of a great help.
yeah, but you may still have a difficulty when
Oh
both
yes, oh yes. At the end of the day, it may not be easy.
Yeah. What is the role of corticosteroids? I think in the
It's
end
a
stage there's a
controversial.
role.
It's
But
controversial. It's
when
very
the patient is
controversial.
when the patient's very sick, Jay, there could be
Because
a
what they
role.
say in the initial stage, when you think the storm is just starting,
Yeah,
48 hours people have tried 80
Yeah.
milligrams of the methylprednisolone BD for 2 days.
yeah.
Some people say it produces very good results, right? Okay. I mean, we don't have a last word about it.
We have somehow skipped the slides on the monoclonal antibodies. Can you just put a
You
little
see,
word in
these
about the
monoclonal antibodies are very, very difficult for our country. Number one, they are very, very expensive,
but
not
we can
practical for our country.
no, but we can
And
use it in the storm situation, no?
we can use it, right? But not the results are very great, to be honest, right? Okay. You can't really, and the cost from that point of view, they are saying you give it a combination of the hydrochloroquine, sorry, HCQS, and the colchicine brand. They are talking about it as an immunomodulator,
Yeah,
colchicine, right? Which
yeah,
can be given a
colchicine.
good trial without much harm, right?
Yeah. So we are not mentioning any doctors' names. I'm sorry over here because otherwise people may feel left out. We cannot take all the questions. But I'm going to just say, what is the role of anticoagulants in patients already on aspirin? I think aspirin
It's
does not
significant.
protect. You may actually have to give the anticoagulant and stop the aspirin at that point in
Right.
time because aspirin may increase the bleeding risk
Yeah,
of the
it's a
patient.
it's
So
a
it's
very high
better. Yeah.
prothrombotic state,
Yeah,
right?
so you better take the anticoagulant and not the aspirin, unless the aspirin is very, very much indicated.
Yeah.
Uh, yeah. So I think we have covered most of the questions, Jai.
Yeah,
Hemant, unfortunately, Hemant is
locked
got
out. Yeah.
locked out. I must thank Jai and Hemant for giving us a very, very good insight into this novel approach of COVID and also taking us through the symptomatology, both the regular symptomatology as well as the new kind of patients that we are getting with a different symptomatology. So thank you very much, both of you. I must thank JB Pharmaceuticals for giving us this platform, Vikas and Milan and all the rest. And can we have one of the people from JB Pharmaceuticals now to come in and talk to us?
Sir, thank you so much. I think wonderful coverage. I think the mode of discussion was very nice. I think it will be very, very, I think, understandable, and doctors also, and all of us being a I mean, medico segment also, we could relate and we could understand a lot of your conversations. So I really, at this onset, I would like to thank Dr. Bran Pinto, Dr. Jadwani, and Dr. Hemant Thakkar for their lucid presentation and lucid talk about this epidemic which is there across us. Also, I like to thank all the doctors who have taken out their time and logged in tonight. And I hope the today's webinar would have served their purpose. So thank you, sir. Thank
Thank you,
you
Vikas.
for taking your time, and
Thank you. Thank you. All
thank
the
you,
Bye,
sir.
best.
Brian. Thank
Bye.
you.
Thank you,
Bye.
sir.
Bye, Jai.
Thank you.
Hemant, stop.
Thank you.
Close it. Leave meeting. Thank you.